I'd like to introduce first. First of all, we have a substantial portfolio in our in NIDA, like Wilson said, in the clinical medical branch of a division of therapeutic and medical consequences. We have several important grants on HIV and hepatitis C, and I'm pleased to have Dr. Linnes and Dr. Kovacs, who are grantees with us. Dr. Linnes has a DP2, a prestigious Avenir Award for HIV, and she's extending her studies on hepatitis C. Dr. Linnes is a Marta Gross Associate Professor in Purdue University, and she has a PhD in bioengineering and graduate certificate in global health. She has worked on developing special techniques on point-of-care diagnosis for underserved populations. She not only cares for the technical part of the strategies, but also for the population studies, trying to implement those techniques in the underserved population. With that, I'd like Dr. Linnes to go ahead and present her seminar.
Thank you so
Jackie?
much.
Yeah.
Really appreciate the opportunity to be here today. And as I get slides up and running, want to talk a little bit about our transition and expansion of our work from HIV infection detection to hepatitis C virus detection, with much thanks to Raul and to NIDA for supporting these efforts. So we know that the hepatitis C elimination is feasible in the United States, and I'm leaving it to Doctors Florence and Collins, who have a great discussion about this opportunity. And from them, one of the biggest problems is in testing, and that it's not available in every community, and that testing requires multiple steps before a treatment can start. And so some of the solutions proposed are to expand testing locations so that we can increase access, and to use new point-of-care tests to allow for rapid testing and treatment. And that's the area that we've been focusing on. We started focusing on this for HIV because the US and the world are not on target to meet the 95-95 goals for HIV, and awareness of infection status is one of the biggest bottlenecks, followed by getting people aware to be in care and to onto antivirals, and then of those individuals reaching viral suppression. So starting at that first step, we've been thinking about this. How do we get more people in care? And it really is deploying new testing strategies and reaching people where they are. So healthcare access points include hospitals, clinics, and really getting out into the community. And so we've been targeting those community locations, reaching people at harm reduction sites, syringe service programs, and people experiencing homelessness, high-risk populations that don't otherwise have easy access to other healthcare points. And when we do that, and with any diagnostic, we really have to consider what is the accuracy, the affordability, and the accessibility of these technologies. Right now, the most accessible technology you can find is a lateral flow test, also known as rapid diagnostic tests. You probably used one for COVID at one point. They're so available that the US government's able to send them to mailboxes throughout the country. What you may not know is how they run. And in the case of HIV and hepatitis C, it's a finger stick of blood that contains a little bit of virus, but mostly the antibodies that your body has produced against them, flows onto the strip. Those bind to gold nanoparticles that have other detection antibodies against them. They continue downstream to the test line, where you see that development. It's the gold piling up, followed by a control line for any extra nanoparticles. And then you're able to tell very simply 2 lines yes, 1 line no, whether there's been a positive or negative response. So these do exist for hepatitis C and for HIV. The question would be, why not just use those? And the answer is because the current testing process and how long it takes your body to produce antibodies. Right now, the CDC recommended testing sequence for identifying current HCV infections is to do one of those antibody tests. If it's non-reactive, you can stop, but I'll come back to the little star. If it is reactive, then you go to look at the viral RNA for a current infection. If that's not detected, then you can continue following up as appropriate. If it is detected, then you are linked to care. But if you go back to the little stop sign on the left, if you've been exposed in the last 6 months, then you are still recommended for HIV RNA testing. So there's becomes a second step, and then follow-up testing with antibodies if RNA is not available. And that's because despite getting infected, most people within that first year, it takes almost 6 months, 3 to 6 months for antibodies in your body to develop. So the virus is growing in there and producing RNA and a little bit of antigen available in the blood from the surface of the virus. But all during that time, you haven't produced enough antibodies to respond. So, whoops, sorry. This is during the seroconversion period. The antibodies are produced, and then in the case of HCV, you can actually clear the virus in some cases, but those antibodies are continued to be produced for years, whereas the RNA and those antigens are gone when you're no longer infected. And so if we could detect that earlier stage when you're actually infected, that would be of benefit. However, at this point, we're a bit, we either have affordable and accessible, but not as accurate antibody-based rapid diagnostic tests, or accurate, but not as affordable and less accessible RNA tests. However, I'm putting the Cepheid gene expert here because that being that very first approved HCV near patient test where this could be in clinics. It's about a little bit bigger than the size of a toaster, so it's not necessarily going to be easy to get out to where we're thinking of, but it does bring things much more close to access. That said, there's a global need for accurate, affordable, and accessible acute HIV and HCV diagnostics that we are targeting. And so our goal is to combine that accessibility and affordability of paper-based rapid tests with the accuracy of those nucleic acid diagnostic tests and really target the virus and the viral RNA itself. The way we've been thinking through this process has been a test that the blood lands on, just like your rapid test, and then goes through different processes for lysis of the virus to open it up available for nucleic acids, RNA amplification, and then detection on a readout that's the lateral flow test readout. And we have developed these little wax valves that help to move the process along from point to point without the user having to do a lot of additional steps. The conflict of interest that I have is that I am a co-founder of a company, Evertrue, that is working to commercialize this platform. All of the research that I'm presenting so far is from my academic lab, though. So back in 2019, we had come up with this concept for MicroRAD, Micro Rapid Autonomous Analytical Device. It was going to do everything from sample to answer. And we're getting there. So we were able to develop this using nucleic acid amplification that is loop-mediated isothermal amplification, or LAMP. It uses a crude sample. You can put whole blood in if you dilute it a little bit. It needs a heater to get to 60 to 68 degrees and a timer, but it doesn't need a lot of instrumentation the way PCR does to cycle temperatures. You can hold it at that temperature for 25 to 60 minutes, and it goes through this biological process in the background where it becomes producing billions of copies of your target. And you'll notice the little star in the circle, and those are tags on the primers that you've designed against this. And those can be read on the lateral flow test, which makes it a very simple 2 lines yes, 1 line no readout that folks are familiar with. The fluid control that we use, these little wax valves, were the sort of secret sauce to move things along, as I mentioned. And when we're done, this device looks like this image here. And so your sample goes on the white pad, the buffer in the green, and when we amplify it for 60 minutes, this is sped up 150 times so that we can not watch it for the whole video. Everything is making its nucleic acid amplicons, and then these valves are heated to 80 degrees C, and everything, all the liquid gets pushed downstream for the lateral flow readout, which you can analyze. We waited conservatively for a full 90 minutes, but you can do that in less time. For your user, add sample, add buffer, close it up, heat. It automatically heats with the electronics inside. Those run for their cycle of 30 to 90 minutes, and then automatically gets to the readout. And we really thought this was an elegant way to demonstrate that we could detect HIV from whole blood with positive and negative samples. When we started this, we wanted to increase the limit of detection to make it more sensitive, which we're still working on, but we've got a start. Now, as we were thinking about this from a very technology-centric perspective, we started talking with our public health collaborators about, well, would an hour-long test be competitive compared to a 1-minute or 20-minute antibody test? And so we've really started refining our process for doing this by using stakeholder-informed feasibility and accessibility, iterative device design, and then training community health workers so that they can help us design and evaluate usability tests. This community and stakeholder engagement in the engineering design process is essential. We teach it to all of our undergraduate students, and it's often ignored when professionals are doing this ourselves. This successful uptake and adoption of these technological innovations requires understanding of the need and the context that these are being implemented in for. So not just the end user who's using it, but also anybody else who's impacted becomes an important stakeholder. And we always recommend engaging and listening to all of those stakeholders. We can't always do that ourselves, so we collaborate with the Health Tequity Lab at Purdue University, led by Dr. Natalia Rodriguez, and use their expertise to help train researchers in my lab and help them to learn how to go out and ask the right kinds of questions. And so engaging diverse stakeholders in identifying key requirements is something that we've learned how to do from them. Those stakeholders that we've worked with so far include healthcare providers that we've done interviews and focus groups with, patients, and community health workers and community leaders. Less formally, we've gone out and talked to policymakers, manufacturers, and distributors and other payers for the technology to understand their perspectives as well. But I want to share with you some of the work that Dr. Rodriguez led in that evaluation in designing an HIV diagnostic. We started doing this in 2020, so there were some complications, but we learned a lot from innovations from COVID as well. Using the socio-ecological model to guide the process, we had 15 interviews of HIV and AIDS service organizations around Indiana. And really the central question was, would this be a feasible test, and what is happening right now? So currently blood is sent out to central laboratories for testing, but overall the response was that yes, it would be worth a 1-hour point of care HIV test. Thoughts from various individuals that could detect a month or so earlier than regular antibody tests because we can detect the virus RNA, were that yes, it would be feasible. So reducing HIV transmission, a lot of people share needles, and the sooner you know that you're positive, the sooner you can stop exposing other people. Obviously, keep it contained, and that's really important, from one of the clients of the organizations. Another client said that I think there is a need, because the sooner you know about it, the sooner you can start treatment and start trying to keep it from getting worse. So there's very much an interest from the beneficiaries of the technology. We also wanted to find out whether this would be better implemented as a self-test, or if someone going into the community, like a community health worker or peer recovery specialist, would be better leading the testing. So again, we went and had more summary-structured qualitative interviews with HIV service organizations and their clients. Found that some of the benefits of at-home testing were access and convenience and privacy, peace of mind. Concerns were also accuracy, usability, interpretation, self-reporting, lack of a path to follow-up, similar to the lack of counseling, and potentially increasing the stigma because it was thought that if you have to do it in the privacy of your own home, it might not be it might be further implying that it was something to be ashamed of. Some of the really interesting discussion points that were had, a client thought that in the terms of privacy, I think it'd be cool to be able to do it yourself. A lot of times I feel like some people might have a sliver of doubt where, you know, if they did something, if something did happen, maybe they would just want to be able to test themselves in private. On the flip side, concern expressed by providers was self-reporting. If I'm self-testing, you're home alone, you know, am I gonna report myself if it does come out reactive from a counseling and testing program manager? So what is the path to follow up? Similarly, on that peace of mind, I can be by myself, and if I imagine or wonder or have any issues or whatever, then it's easy to do. And, you know, I go on from there. Like I said, at least I know I'm good on my end. So that the value of having a negative result was another client consideration. The concerns on the positive result, if a person turned out positive, they're there on their own in that moment, and that would be a traumatic moment. You don't test yourself for cancer and find out all alone that you have cancer. So that would be dramatic. And I think that's a really valid consideration that our clients are bringing up here. And the community health worker and peer-led testing, many of the same benefits, access, someone who's skilled at building trust, but a lot of focus on that human element that having somebody there with you is able to bring. So educating and supporting, bonding through shared experiences for peer-led testing, and having a safe, non-judgmental space. Concerns being that you're limited by budget and institutional policies and capacity, gaining trust with the individuals and the emotional well-being of the testers themselves. So one of the aspects that we were considering financially, but not policy-wise, was brought up. We're limited by our budget and limited by what we can, as an institution, can do. We used to go to the jails, and then they changed the rules, so now we can't. And so thinking about, I'm very aware that technology is not going to solve any problems on its own, but working within the context of the outreach coordinators and testers and community health workers that are really doing the work and seeing where this can be implemented. So key considerations that we saw: ensuring accuracy, considering the cost to the clients and the organizations that are delivering these, creating a test that is simple. Before I go too far, one client said, as long as I can trust the accuracy and all, yeah, you know, why not get tested? Which is great to hear. Another, create a test that's simple and simple instructions. As long as the instruction's clear, everything, that would be fine. Also, what to do if you test positive, and that emotional support and counseling for self-testing. Noting that these are all very important considerations and are concerns that we have even for self-testing today with HIV and HCV antibody tests that are available. So thinking through these, we're going back to our process and iterating on our device design. Right now, we have a sample control to improve the interpretation accuracy so that you know and can be confident that your test functions the way you expect it to. So here we've added a third line, which may make it a little more complicated, which is why we're going to go back and work with the community and ask them. But we have our control flow that makes sure everything got there. but also this 18S rRNA human amplification control that ensures that you have enough sample and that the chemistries are still functioning properly so that the reaction can amplify. So both of those should always be there. And then the test line, in this case, looking at SARS-CoV-2, will only be there when you have antigen, or if you have the RNA of interest. So at 0, you only have 2 lines. Everywhere else, you have 3 lines. So in this case, we'd have to change it from to 2 lines, yes, 2 lines, no, 3 lines, yes, and 1 line would be a test failure. So there would be a little more engagement and training, as even I have to describe it correctly. But we think that that is reasonable and that people will be able to count to 3 and be able to do the test that way. After that, we're going back to community health worker training for usability studies, getting feedback, and working on this process for hepatitis C specifically to find out what are the concerns that individuals have with that. The other thing that we're trying to do is simplify the device to reduce the cost. So we know that number of parts is one of the expenses. So we've taken this from 14 parts down to just 6 components. And we expect that that is going to be much lower cost. And further, in order to prove that and demonstrate it to ourselves, we made our own little low-cost assembly setup so that we can see just how many steps it takes to put everything together. And here you can see the little redesigned parts, and we put the wax valve on the lateral flow test and the amplification area so that we can try these out ourselves. So in conclusion, we're modeling a human-centered approach to health technology design. We've got evidence of acceptability and the benefits of acute HIV testing that I hope will apply to HCV, and context-specific considerations to improve the design and facilitate adoption of the devices. Next up, we're going to do this specifically for HCV design specifications. We have our IRB approved and ready to go. And we're acquiring iterative feedback from the HCV stakeholders on the usability and feasibility in intended settings. And we want to continue engaging broader stakeholder groups, people who aren't yet in care, payers, manufacturers in the process of device development, with the goal that we can get accurate, accessible HIV and HCV testing for the whole community. Thanks to everybody in my lab that has contributed to this, collaborators, particularly the Health Tequity Lab and our Indiana HIV aid organizations and clients, and our funding sources from NIDA and the Gordon and Betty Moore Foundation that particularly helped us with this stage of involvement in the design and scale up for HIV and HCV. With that, thank you all very much.